Good morning everybody and welcome to our third live streaming session for today. This is the impact of chronic health on workplaces, and I'd like to introduce you to Samantha Jackson to tell us all about the research by Menzies Research Institute. Thank you, Samantha.
Hi there, my name's Samantha Jackson. Thanks for the introduction. I work as the Community Engagement Coordinator with the Menzies Institute. We're really pleased to be a part of this today. We wouldn't be the institute we are without the support of the Tasmanian community. So firstly, thanks for your interest. What we'll do today is give you a bit of an update on research happening in the area of chronic health at Menzies. So we'll have two speakers, Dr. Shauna Gore and Michelle Kilpatrick as well. So I'll introduce Shauna first, who will talk around her research on the chronic health diseases in Tasmania. Shauna has been with us since 2006, completed her PhD at the University of Melbourne in epidemiology, and is well recognised within her field with a particular focus on cardiovascular disease. Shauna.
Thanks, Sam, and good morning to everyone. So yeah, I'm going to be talking today a little bit about chronic diseases in Tasmania and Australia, and also some of the research that I've been involved in at the Menzies looking at chronic diseases and risk factors for chronic disease. So when I'm talking about chronic diseases, I'm talking about a range of conditions that are recognised by the fact that they are long-lasting and persistent. So these are things like arthritis, asthma, back pain, cancer, cardiovascular disease, and mental health conditions, for example. These types of diseases are very common. So around about 50% of Australians have any one of these chronic diseases, so these are very common things within our population. Chronic diseases are not distributed evenly across the population. So if we look at this nice graphic from the Australian Institute of Health and Welfare, we can see that they are much more common in older people. So in people over the age of 65, 87% of people have any one of these types of chronic diseases, whereas people under the age of 45, it's lower at around about 35%. Females are slightly more likely to have chronic disease, and people that live in lower socioeconomic status areas are also more likely to have a chronic disease. And we also see that there's a greater burden of these diseases amongst people living in regional and remote areas compared to those in major cities. If we look in a little bit more detail about the different types of chronic diseases and how common they are across different age groups, on the left-hand side of the diagram and between males and females, you can see that in younger people, so people under the age of 45, the most common chronic diseases are those related to mental health. So these are things such as depression and anxiety. And in the older age groups, it's predominantly cardiovascular diseases and also arthritis. In males, cardiovascular disease is the most common type of chronic disease, whereas in females we see that mental health conditions contribute to much more of the burden for females compared to males. The reason why we're so concerned about chronic diseases and want to understand ways to prevent them is that these diseases are associated with a very big burden on the individual that has them, the entire population, and also the healthcare systems. So what we can see is that around about 30% of conditions that are managed in general practice are related to one of the chronic diseases I've talked about, and that 40% of preventable hospitalisations are related to one of these chronic diseases. Together, these diseases contribute to around about 60% of the total burden of disease in Australia. So this is when we're talking about deaths occurring from a disease, but also disability associated with the disease. So these are the diseases that are causing the most burden of disease in our country. And this bears out in that we see that about 70% of deaths are attributable to a chronic disease. So we obviously want to understand better ways to prevent chronic diseases from happening. And one of the ways we can do this is by looking at the risk factors for chronic diseases. One of the striking features about the diseases I was talking about, so things like cardiovascular disease, diabetes, and musculoskeletal conditions like arthritis, is that the risk factors, or the things that cause an increased incidence of these diseases, are very similar. So this graph here shows the proportion of people in the Australian population with some different risk factors. So smoking, around about 15% of Australian adults smoke every day. A very alarming, around about 90% of people have what would be classified as a poor diet. A very high proportion of people are physically inactive. Around about 15% consume alcohol at harmful levels. We know that overweight and obesity is a big problem, and around about 60% of people are defined as being overweight or obese. And then some more sort of biomedical risk factors like high blood pressure and high cholesterol are found in about 20 to 30% of people. Now, if we look across these different risk factors, which are very common in Australia, we can see that there are commonalities in how they're associated with different chronic diseases. So things like smoking, diet, physical inactivity, and overweight and obesity increase the risk of developing arthritis. These 7 different risk factors I've shown here account for about 90% of all strokes that occur. And if we look at these 4 sort of behavioural risk factors, as we like to call them, like smoking, diet, physical inactivity, and harmful alcohol consumption, if you have these risk factors, you're 5 times more likely to die of premature heart disease than if you did not have these risk factors. And I'm sure everyone's aware that smoking alone is associated with at least 16 different cancers. So even though these figures are alarming, what's actually quite promising about this is that these are all risk factors that we can control through either changing our behaviours ourselves with the help of people like general practitioners and nurses, or they can be controlled through medications for things like high blood pressure and high cholesterol. So in theory, chronic diseases should be preventable. So at the Menzies Institute for Medical Research, the research that we do is organised under 5 different research themes, and these really cover off on the major chronic diseases that I talked about earlier. There's a theme devoted to public health and primary care. We also look at cardiometabolic health and disease, musculoskeletal health and disease, neurodegenerative diseases, and cancer, genetics and immunology. So across these different themes, the research that we do there is bench or lab-based research looking at the origins of disease in a cellular way and a molecular way. There's research conducted in a clinical setting, so at the bedside. And then we also do research in terms of populations. And ultimately what we're hoping to achieve is to, by engaging in this cycle of research, to improve outcomes for patients and the population. So as I said, chronic diseases in theory should be able to be prevented through living a healthy lifestyle. But one of the things we've been looking at is how common it actually is to have a healthy lifestyle that should prevent these diseases. And one of the studies that I work on is called the Childhood Determinants of Adult Health Study. And this began back in 1985 with around 8,500 school children that were aged 7 to 15 years. And we followed these people up over time into adulthood. So the people are now aged in their mid-30s to mid-40s, and we're still following them up to this day. And one of the things that we are interested in looking at is the healthiness of people's lifestyles in terms of who has healthy lifestyles and what effects these different lifestyles have on people's health. So the way that we've done this across a number of different studies is to calculate this healthy lifestyle score, where we use a combination of people's questionnaire responses and also measurements we've taken from them around their physical activity and things like their weight, across things such as their diet, their alcohol consumption, their smoking status, the amount of activity they do, and also their weight. And we've then had a look at some different factors associated with this and how it's associated with some different health outcomes. And so what we found is that many people have unhealthy lifestyles, even very young people. So this, the graph that I'm showing here shows the bars are the proportion of people, so males are in blue and the females are in white. And the score along the bottom here indicates their score on this measure that we use, where 0 means people had no healthy behaviours and 8 means they had all of the healthy behaviours. So someone with a score of 8 is a healthy weight, they don't smoke, they don't drink, or they drink very low levels of alcohol. They have a very well-balanced diet, and you can see that almost nobody falls into that category, so it makes me feel a lot better about things. Someone down the other end is at the other end of the spectrum, where they have a whole range of unhealthy behaviours. So we can see that around about 20 to 30% of people fall into a category where they have very few healthy lifestyles. And we can see that men are more likely to be in this lower range of the score than women. And what we did then was we had a look at how this score related to some of the risk factors that are associated with chronic disease, and particularly cardiovascular disease. And we can see that these people's lifestyles are already impacting on their physical health. So we have a range of different measures that we took in some study clinics. The thing I didn't say about this study is that it's conducted all around Australia. So we have Tasmanian participants, but also people in the Northern Territory and Western Australia and so on. So we did basically like health clinics where we took a lot of measures from people. So this is showing this lifestyle score again, where we have people that have a score of 8 have all of the healthy behaviours, and people with a score of 0 have no healthy behaviours. And we can see this relationship where the line is the level of the risk factor. So low density lipoprotein cholesterol is a very strong risk factor for cardiovascular disease, and the people that have very few healthy behaviours have much higher levels than those with all of the healthy behaviours. They also have higher blood pressure and higher levels of insulin. And so, as I said, these are young people. These are people in their 20s and 30s, and to see these kinds of relationships now confirms what we know about these risk factors, but is also concerning because we know that the adoption of healthier lifestyles once you're in your 20s and 30s can be very challenging, and Michelle's going to talk a bit about that a bit later, and that if these people already have adverse risk factors associated with their lifestyles, this is a concern for their risk of developing diseases later on in their life. One of the more recent and very interesting findings that we had was that these healthy lifestyles were also associated with people's mental health. So using this same score, what we found here was that this bar here indicates what we call a relative risk of 80%, which suggests that for each we assessed people at the start of the study for their lifestyle, and then over a 5-year period we looked at whether they developed depression over the 5 years. And what we found was that for each healthy behaviour that a person had at the start of the study, they were 20% less likely to develop depression over the following 5-year period. And we looked in a bit more detail at whether this was because of particular behaviours in this lifestyle score, and if we took things out like smoking or people's weight, it didn't seem to affect it, which was saying to us that this was about people's overall lifestyle and that no particular risk factor was important for maintaining mental health, but they were all contributing to people maintaining mental health these people were then in their 30s to 40s. So one of the other things we've also looked at within this study, which is particularly pertinent to workplaces, is around job stress and its role as a risk factor for chronic disease. And one of the measures we use here is called the Effort Reward Imbalance Scale, which measures people's job stress by looking at the amount of effort required for their job and comparing that with the amount of reward they get from it. So this is related to their personal feelings about it, but also things to do with salary and job security and the like. And so people that have a big imbalance between these two things it can be considered to have a high level of job stress. And there's quite a large body of literature showing that people that have high levels of job stress are at an increased risk of a range of different chronic diseases, and particularly things like cardiovascular disease. And some people have suggested that this is a direct link where the job stress causes physiological changes in people that increases their risk of diseases. But there's also another pathway that people are interested in, and that's that people that are experiencing a lot of stress may engage in a range of unhealthy behaviours like smoking or drinking or being inactive as a way of coping with this stress. And this in itself might cause an increased risk of chronic diseases in these people. And understanding this pathway is important for figuring out ways workplaces and people themselves might manage these things to reduce their risk of chronic disease. So what we did in the study that I was talking about, the Childhood Determinants of Adult Health study, is that we looked at the measure of people's job stress and we looked at their health behaviours, and we found that there was a link. So that the people that had very high levels of job stress in men, the men that had higher levels of job stress ate worse diets that had more of what we call extra foods, so foods outside the dietary guidelines. They were more likely to spend more time being sedentary on the weekends when they were not at work. And if we looked at that overall lifestyle score that I talked about, the men with high job stress were scoring lower on that score. And in women, we also found some associations with the overall score. Women that had higher levels of job stress were more likely to be current smokers. They were more likely to drink what we would call harmful levels of alcohol, and they also had poorer diets than those people with lower levels of job stress. So in summary, chronic diseases are very common, but they're also very preventable, and our research is showing that adopting and maintaining a healthy lifestyle across your lifetime will reduce your risk of chronic disease. And at the Menzies, we are conducting research in a range of chronic different diseases, and this is from the bench to the bedside, ultimately to you in the population, trying to reduce everyone's risk of disease and improve their health outcomes. Thanks.
Thanks, Shauna. So I'll just introduce now Dr. Michelle Kilpatrick. Michelle completed her PhD last year looking at health, workplace health promotion, and is currently working on a bariatric surgery project with the state government. She's going to give you some information and resources that are relevant in a workplace setting today.
Thank you, and thanks to everyone for their interest in today's talk. So just to give a brief outline, I will touch a little bit on chronic health issues because Sean has done such a fabulous job. Also have a look at, again, the bi-directional relationship we have between work and employee health and wellbeing, and vice versa, employee health and wellbeing and work, the impact that work can have on health. Touch on some of the work that I did in my PhD and also what is happening elsewhere. And I thought it might be really useful to provide some links to some resources. There's some great things out there at a state level and also at a Commonwealth level. Just to touch on some of the work I've done, I began my work in workplace health promotion and mental health promotion in the Business in Mind project. I think my slides have had their timings saved to them accidentally, so I suspect they might jump around a bit. I apologise in advance. So the Business in Mind project was a project funded by the Australian Research Council, and it also had partners in WorkSafe and Beyond Blue. And I was involved in developing a resource that was to go out to managers in small to medium-sized businesses to help them manage their own mental health and wellbeing and also that of their employees. I really enjoyed that work and then had the opportunity to further that interest in my PhD within the Partnering Healthy at Work Partnership Project. And that was a project with Menzies and the Tasmanian State Government that was helping to evaluate the Tasmanian State Government's Healthy at Work Workplace Health Promotion Initiative. My particular focus in that was looking at the engagement the employees had with the activities that were offered as part of Healthy at Work, with a particular focus on the health-related behaviours that Shauna has touched on already. Also, as part of that PhD, I was able to be involved in the pilot evaluation of the Commonwealth Healthy Workers Initiative. So there was a set of resources and programs developed by the DHHS as part of their response to the healthy workers. So that was looking at it from a Commonwealth perspective. Sean has already touched beautifully on health-related behaviours and mental health and the impact that they have on and the well-established association with non-communicable diseases and the risk of premature mortality. So I won't go on about those, but I looked at all of these with the exception of mental health in my PhD. So I wanted to talk first about the impact of health on work. So there's been a vast body of research that's looked at employee health risks and poor health and the effect that that can have on the workplace and work. In America, there's a lot of research that focuses on the costs associated with that due to the medical costs that are the burden on the employer. We don't have that issue in Australia with Medicare, so a lot of the research in the Australian context is focused on the indirect costs, so productivity. And as I said, there's well-established links between employee health risks and poor health and impaired work productivity. We tend to divide that into absenteeism and presenteeism. So obviously absenteeism is time spent away from work through sickness. And presenteeism is a relatively newer concept where you're looking at people who are coming to work despite being in poor health and their productivity is impaired, or they're obviously performing below par. Again, there's a lot of research that's looked into the different health conditions that are associated with both absenteeism and presenteeism. There's good, strong links between a range of health conditions, including some of the things that Shauna touched on, so arthritis, lung conditions like chronic obstructive pulmonary disorder, those sorts of things associated with absenteeism and presenteeism. But particularly when you're looking at presenteeism, where you see stronger relationships with mental health issues, so psychological distress and drug and alcohol problems. So that's the way in which you can see employee health affecting perhaps the workplace. That's the most strongest cause. And there are various estimates. A recent one looked at presenteeism having an estimated cost to the Australian economy of $34 billion a year, which I almost had to double check to make sure I hadn't mucked up my millions and my billions, but that's quite a sum. So I also think it's really important to consider the impact that work can have on health. Again, Shauna has touched on this briefly, but we know that the type and quality of work that people do can negatively impact their health. Some of these, again, Shauna's touched on, so work stress is a huge one. Obviously, there's psychosocial hazards, bullying, emotional labour, which is where the demands of someone's job are such that they're having to perform in a way that's a mismatch with what they're feeling internally. So you commonly see that in customer service. So when people are having to put on a face and say, I've just lost my train of thought for a moment, in the face of, say, a negative customer experience. Obviously, there's the work environment, and a lot of research has gone into work patterns, so people who are working long hours and shift work. And you can see that that could affect people's choices in the way that Shauna noted. So if you're exhausted and having irregular work patterns, it can impact on the way that you can look after your health outside of work. So there's a strong link there with poor employee health outcomes. Also, again, still looking at work and health, on the flip side, work can be good for health and well-being. Again, lots of research into this. It can provide adequate economic resources for material needs. So you've got the money that you need to have a house, buy reasonable food, and to participate fully in society. It's also one of the most important drivers for inequalities in health. So this is something that I looked at in my PhD, looking at promoting health via the workplace, because this is a setting that has been recognised as being important for health protection, health promotion and disease prevention. And there are a raft of different ways that you can consider promoting health in the workplace. And there's some good evidence that if you have a program that is well implemented and evidence-based, you can expect to see some small changes perhaps in people's behaviours. But I like to think that there's a number of other factors that people can consider. And my slides have frozen, so I will just discuss them and hope that they will wake up shortly. Some of the other things that are really important to consider beyond behaviour change, which of course is what we would all love to see, are some of what I call the interim benefits. So if you're an employer considering a workplace health promotion focus in your workplace, there's things such as increased job satisfaction for your employees, improved morale, job retention, all sorts of things that are much harder to measure, but I came to realise in the course of my PhD, which was rather focused on activities and behaviour change, that there's all these things in the middle that go towards a positive health climate that I think are almost as important. And still frozen. So
maybe call on them to stand up at their desk.
Yeah, everyone have a rest.
Take a well-being break.
That's okay.
It was all part of the plan, Michelle.
It was all part of the plan. I can keep talking, perhaps. I could tell you about partnering healthy at work. Shall I do that?
I think I'll have to end it.
I have to end it. Yeah, that's right. So now might be a good time to tell you about the project that we're working on. So Healthy at Work was, as I said before, the initiative that the Tasmanian State Government rolled out between 2009 and 2014. And it was quite the undertaking. They were having to look at a program that would reach the entire employee population, which was something like 30,000 employees at the time. And that's across a diverse range of locations and occupations. So obviously you've got police, education, health within the Tasmanian State Government, all with their different needs, all with their different work patterns. And the Menzies, some clever researchers at the Menzies came on board and thought this is a great opportunity to look at a program that's being rolled out on best evidence principles. It was a comprehensive program in the real world, and we'll see what can happen. So they applied for some funding, and we ended up with the Partnering Healthy at Work project, which was a large team of researchers from the Menzies and University of Tasmania, working in collaboration with the Tasmanian State Government. The key focus we were wanting to achieve was to look at a number of different aspects of the Healthy at Work program. We had Dr. Lisa Jarman, who worked on the mental health side of things. We had Cyan Baxter, who looked at Dr. Cyan Baxter now, who we looked at the health economics side of things. I was looking at lifestyle factors and employee engagement. But there are a number of other things. We had process evaluation and a whole raft of research, which I will hopefully touch on. So Partnering Healthy at Work ran from 2010 to 2015. I particularly, as I said, spent a lot of time looking at barriers and facilitators to participation. And we're getting closer. Next one, I think, a couple along. Here we go, increased productivity. So these are some of the interim factors I was talking about from memory. So some of the things that you can, if you're thinking of running your own program or have a program up and running, these are some of the things that you can foster in addition to looking at employees and their health-related behaviours. One of the things that Cyan Baxter set up in her PhD with the health economics focus that she had was to look at ways that, an easy way that workplaces can justify or assess some of the costs that might be associated with having a workplace health promotion program against some of the savings. As I said, in Australia it's a slightly different setup than America. So we're looking really at the lost productivity costs and staff turnover. So she came up with this calculator, which was so well received that the Healthy Workers initiative picked it up and put it on their website, and that's still available for anyone that's interested in having a look. So just quickly to consider what is best practice for workplace health promotion, it's a comprehensive approach. It's a coordinated application of health promotion and protection strategies. And the whole idea is to create an environment that's conducive to improving employee health, well-being, and to help people make healthy lifestyle choices. It's considering the physical, social, policy and cultural environment, so it's a whole of environment approach. There are a number of different models available. This is one from the Centres for Disease Control and Prevention in America. There are lots of similar ones, including ones that are offered through the Tasmanian-based resources. But they all essentially have the same elements. It's an assessment phase, a planning and management phase. You implement a program and then you evaluate it. And the idea is it's a cycle and you keep going with it, and you're probably all familiar with that. Healthy at Work, as I said, was a program that tried to adopt this evidence-based approach to a comprehensive workplace health promotion program. As I said, it was implemented across all the agencies. They tracked progress. They had a small centrally coordinated support team. They provided training for facilitators within all of the agencies. And there was also a focus on those lifestyle risk factors that we've already discussed. How hard could that be? As I said before, you've got a number of different occupations, locations, I think something like 1,500 work sites. So it was probably just as well, given the technical hitches, that I hadn't gone into great detail into the research that we did, because there was so much of it. There's something like 16 publications from it. I thought it was better to draw attention to the final report, which is, as of today, available on the Menzies website. It's so hot off the press I didn't have a link to put in for today's presentation, but if you just Google Menzies and Partnering Healthy at Work, you'd be able to find it, or email me. This report summarises the project findings. It covers what we did in terms of mental health promotion, the lifestyle factors, the engagement that we saw with the activities, and the health economic evaluation. What I thought would be a good idea to do would be to pull out some of the key recommendations from that report. So when we looked at all of the research that we did and try to draw out some key themes that we could provide people with, it was that using this comprehensive approach was actually, we saw some signs that that was a really good way of starting to embed a program within such a large organisation. We saw that agencies that did try and integrate health promotion with protection did well, and we're setting it up with existing occupational health and safety organisations or committees. That where we saw agencies really tried hard to embed the programs within core business. So that's getting the ethos of a health promoting organisation within everything, policy, collecting routine data that can help support a case for a program. We saw some evidence that where people built capacity and support for the program by training key staff, so if you had someone whose job it was to run the program, even if it was half a day, there was evidence that the centralised program support was really useful to people, and when that component of Healthy at Work no longer received funding, it was harder for the agencies to maintain a focus on the program. This is a key one for me. Be really clear about the values and expectations you have of a workplace health promotion program. As I said, there is often a focus on the lifestyle factors, risk factors, and that is obviously a key one that we'd all love to see change on. As Shauna pointed out, that's difficult. Given all of the ways that work can affect health and health can affect work, I think it's important to consider some of those interim outcomes that I talked about as well. It takes a long time for people to make a change, and even a measurable change, even longer for a measurable change. So have modest expectations. If you're running a program, it is going to take a long time, potentially up to 3 to 6 years, 8 years are some estimates, to really embed a program and to see some change. And they're probably the key points. We were really lucky to work as a partnership with the researchers and policymakers, and so we were able to inform the research that we did with practical outcomes and policy relevant questions from our partners. We're happy to take questions if anyone has some. I think we need to do them via text, is that correct?
0409
0409
758
758
104.
104.
And perhaps while the questions come in, because there'll be lots.
Yeah, I can say a few words. Yeah.
Thank you.
I'm a good time filler. So I thought whilst those questions are all buzzing into Cameron's phone, I'll say a few words about Menzies. Menzies has been around since 1988 and we have a strong affiliation with the Tasmanian community. We're heavily focused on the diseases that are prevalent in Tasmania, and we really are thankful for the support and interest of you all today. We're absolutely focused on research excellence, distinction in training and education, our co-located facilities. If anyone knows us, most people know our building. It's usually loved or hated. It really does foster the idea of collaboration between aspiring health professionals as well as medical researchers. We're also really focused on ensuring the translation of research into improved patient outcomes with a particular focus on Tasmanians. I'm frozen too now. All right, I can keep talking as well. So in 2016 at Menzies, we have over 300 people working with us, around 65, 66 research academics and around 100 students who really form the power or the body of research activity at Menzies. There's a lot of things that you can do if you're interested in hearing more from us. We offer a range of public events, things like public talks and annual debates. We recently had one on stem cells, more hype than hope, or vice versa. It was heavily debated, as well as stroke this year, genetics, eye disease and genetics of eye disease. So we offer these regularly. They're promoted on our website. We also have a quarterly newsletter that you can subscribe to. That newsletter will talk also of opportunities to participate in research, which from a workplace perspective might be a great thing to promote to your staff to get involved in. Some of those studies obviously are for research purposes but have a really immediate clinical benefit for participants as well. Some examples are studies, one called CORCAD that's looking for people with a history of genetic history of coronary heart disease, so a parent who's had a heart event before the age of 70 and they're now aged 40 to 70. It actually gives them access to a scan that is otherwise unavailable or very expensive and usually only offered in the private system. And so obviously that has an immediate impact for that individual in terms of if something is picked up, their health can be managed. We have a number of other studies that are also looking for people, things that are looking at people who've had a stroke in the last 2 years and improved rehabilitation outcomes within that for participants as well as research findings. Also people who may have type 2 diabetes, people who may have knee pain over 50 years of age. There's a range of studies that I would encourage you to join our mailing list and get involved in. In fact, I think I've probably got a few up here on the slides that are currently recruiting. So usually our newsletters will have a page like this, which will talk about those research activities that your employees might be able to get involved in. Did I miss anything? We're also always really happy to come and talk to people, so please contact me if you would like to call on a Menzies researcher to be involved in some sort of workplace event or activity. As well as I wouldn't be doing my job if I didn't mention that medical research is incredibly tough and competitive. Funding is incredibly important and workplaces can also support us in a range of ways through workplace giving programs, community fundraisers or donations through a workplace setting as well. So thank you, thanks for your interest. Please don't hesitate to contact me if you have any questions or if you'd like some copies of the slides today or the resources that Michelle and Shauna mentioned.
Now that the slides have unfrozen, I can share with you the resources that I thought might be handy. So obviously there's the resources you can get through WorkSafe Tasmania. There's still a lot on the Healthy Workers website. As of a couple of weeks ago, you can now access all of the Business in Mind resources if you're looking at mental health promotion in the workplace. They're available for viewing on the Business in Mind website. There's also the Beyond Blue version that they put together a couple of years ago, which takes a lot of the content but just puts it on their website. There's, as I said, the Partnering Healthy at Work final report, which is now available, and there's lots of stuff on workplace health promotion and in places like the Centres for Disease Control and Prevention and also the World Health Organization. So there's some great things out there.
And before we go, there are a couple of questions have come through.
Oh.
Hello everyone there, live streaming and also the audience. First one is around time, and so through your research, is there, in terms of time to build a sustainable program, how much, it's how long is a piece of string basically, but the average business trying to start up this and implement it, what would be a rough sort of time commitment required to implement a program?
To implement it and to fully embed it, and then to...
Yeah, like an hour, I guess a weekly commitment for an organisation.
Again, it is how long is a piece of string, because it so varies if you're looking at small business down to, something the size of the Tasmanian State Service with all of its complexities. So from my research, I wouldn't have the answer for that specifically. The research does show that to have a fully embedded program, just generally, it can take a number of years to get, if you're looking at policy, all of the environmental changes as well as a well-accepted program that has activities associated with it. So it can take, I think an early estimate would be sort of at least 3 years. And that's one of the conclusions we came to with the Partnering Healthy at Work evaluation for Healthy at Work, where we saw some good signs, but it was possibly just too early to pick up changes in employee behaviours. But we saw some really nice signs to show that they were heading in the right track. So.
Okay, and question 2, just around barriers for workplace health and wellbeing. Are there, if you could list 3 to 5 of the key barriers, what would they be?
Well, the top one that we found and that is in the literature is always time. So people always say I don't have the time for it. That they weren't accessible. If you're talking about participation in activities that are offered through the workplace, that they're too busy at work, that if it's offered outside of the workplace that they have family commitments, that comes up a lot as well too. And one of the things that came through strongly in the partnering in the Healthy at Work was accessibility. So in a larger organisation, there were programs offered perhaps at the central offices that didn't quite make it out to some of the more further flung offices. So just making sure that there's flexible accessibility, and it might even be things like telephone support or web-based, or just thinking creatively to address some of those barriers.
Okay, and finally, question 3. In terms of return on investment, you mentioned Sian's calculator there. So is there and we know Beyond Blue has research around, return on investment for being a mentally healthy workplace, somewhere around $2.30 for every dollar spent. So generally, health and wellbeing, is there a range of return on investment for every dollar spent?
That's a really tricky one to answer, especially because that wasn't my area of expertise in this. But having worked closely with Cyan, who also did a fabulous bit of work around systematic reviews of return on investments, it's really difficult to answer that question because of the quality of economic evaluations that are around. So you have to be careful in interpreting figures that are out there, because sometimes it's due to the quality of the stuff that's been... But, so maybe I could give you Cyan's details if you want an answer to that one.
It would probably be also the background information to the Healthy Workers calculator would probably sit beneath that as well.
It probably would, but that's not my area of expertise, okay. Unfortunately.
Oh, I'm only relaying the text messages. Okay, that's all the questions we have. And would maybe Pam, do you want me to close this one? Yeah. Okay. So a big thank you this morning and this afternoon, because we sort of went into the afternoon, started in the morning. Thank you for the audience for attending, both live and also live streaming, and a big thank you to the University of Tasmania and Menzies Centre for coming forward today and sharing research that's happening around workplace health, and we look forward to continuing the partnership with WorkSafe, University of Tasmania, and getting those great messages out there to Tasmanian workplaces. Thank you.